Oh, sure. Yes.
Thank you for your presentation, sir. Could you describe what you think would be the ideal facility for a person with advanced Alzheimer's?
Other than their home, you mean? By facility, you mean a place that you pay people?
Cannot stay at.
Yeah. Not a place modeled after a hospital. So the nursing home that I told you about, I often remember how it was. They just took the design of a hospital and recapitulated it to have it look. That's the model, the design. There's an interesting history around that. So at least start with the architectural space to feel as unlike a hospital as an institution as possible. But of course, what's most important is who's there and the staff and the people. I could go on about that. Maybe my remarks suggested the kind of people I'd want there. I'd want them to feel about the people there. In the way back.
Taking my question. Has there been any research on people with Alzheimer's who still will recognize the difference in gender? My grandfather was an old school misogynist, and regardless of what he didn't know anymore, he still knew the difference between a woman and a man who was interacting. I just wondered if you had any.
You're asking a physician, has there been any research? That's a very, the answer is I do not know of any research that has investigated that precise question. So now I'll do what a physician does and talk out of anecdote. I remember when I was a little boy, I didn't tell you this story, I was going to, but I had to sort of pick just enough detail, like a good history, right? But I remember when we went to see my great-grandmother a few years later, and she looked at me, and she said, "Who's that little girl?" And I remember my father laughed and said, "Oh, that's Susie." Made a joke out of it. And I always remember that, obviously, because I'm telling it you now, 40 years later, or something like that. Because I'm not sure that was the right answer that my dad gave. And, of course, I was devastated as a young boy, just that, I was confused for a little girl. But I think in reflecting on Richard's remarks and these previous speakers' remarks, which is code for I don't remember. Phyllis. Dr. Swallow. The big challenge is how do you practice loving deceptions with a patient? And I like that phrase, which is, frankly, when do you say things that aren't true or lies, but you're doing it because you love them? I didn't quite answer your question, but it made me think of that. Yeah.
Well, first of all, I do have a comment, but I want the audience to know that Dr. Karlawish, and you may have been able to tell this from his style of presentation, he's not only a physician, he's a novelist, and has published a fine novel about Dr. William Beaumont, who was a St. Louis physician who discovered, by looking into a man's wound, that digestion is chemical and not mechanical, and you can get that. I didn't come here to plug it, but you can get it at Amazon or your Esky bookstore about it. But my comment is that it's just responding to this woman here, that in Beck's nursing home, many of the elder women, I look up when I'm there, and I'm very glad to talk to a man. It's unmistakable. That's what's going on. And, so that gender recognition does last a long time.
That would be my hunch too, by the way. Yes.
You started out talking about the ability to take a Seconal. I forget what it was called, Washington State.
The Death with Dignity Act, right?
Yeah.
So yeah, Seconal is a lethal. At enough dose, you'll die if you take it.
In setting up my own living will and things like that. The biggest issue is at what point, if I'm completely mentally incapacitated. In Missouri, you can't choose to end your life, but will there ever be a chance where you can give advance directive that if I'm such a burden of resources, I would like to not be a burden on my family and on their memories of me? Is that ever going
Well, clearly I at least provoked you as my remarks, and I deliberately steered clear of directly addressing that question because I didn't want to. There is no state in the Union where you can write an advance directive that would allow others to, in that case it would be to euthanize you, because you wouldn't be able to take, on your own voluntary, competent will, take the lethal dose of Seconal. The laws are very clear about that. In Holland, it is possible to euthanize an adult with advanced dementia. The law allows it. There are conditions such as what you've just described that need to be in place. And there's limited use of it, in Holland, and some data reporting on the practice. And they often refer to intractable and terminal suffering as the reason for why they used that intervention on the individual. I've just been turning over in my head a lot, though, that all those laws are all called death with dignity laws. And, dignity word's gotten a lot of play in the last few elections. I've noticed it's getting used in political discourse more. And if anything, I'm trying to reclaim dignity from the left-right fights that go on in our country. I think if there's one thing I hope I've done is at least put dignity back in the hands of the people. Yes?
I am a religious man, and in my work as a hospice chaplain, in which there are a lot of patients with dementia, I'm forced them into a clinical model in which the first question I ask is, are you in any pain? However, I come through it and get to whether someone is in any spiritual pain. And I agree with you all the way that what we're talking about is suffering on an individual, to give them dignity. You do not want them to suffer if you have any power to do that. The only power I really feel that I have is to be present to them, and to listen as deeply as I can to what it is they're expressing, whether they express it verbally or non-verbally. And I'm reminded, as far as dignity, about the story that Dr. Atul Gawande says about this nurse who rushes back to her father's room and says, I don't know what your wishes are. He wasn't in dementia. Eventually he did die of Alzheimer's. But he said, as long as I can eat ice cream and watch football on TV, I want to be kept alive. And then he ends his story and say, the nurse said, my father never watched football.
I think your words speak for themselves. I dare not try. Yes?
Can I get a little clarity in my mind? I'm not quite sure what you meant by your ending sentence about the humanity. You said something about that it is out of our suffering that we find humanity
In advanced dementia. That's correct.
Dementia.
That's
so
right.
You're saying the humanity is not in the person with dementia, but in the person that is interacting with the person with dementia? Or
I think that I'll be lip. I will. I think that it's because of that. The wife who I was speaking of my patient, she is deeply suffering off of the loss of her husband, who's essentially died once and not yet fully, and she's mourning that loss. And those were her words. She mourns him. She mourns that loss. She's suffering, and I think out of that, in some sense, is her bestowing humanity on her husband, that she's suffering for him and with him. And so that's what I think creates the humanity, with that sense of humanity.
that we give each other
That's right.
humanity?
That's right. That's right. And I think that when we begin to feel disgust, and I've used very vivid bodily images because I think the most basic sense of disgust are these sort of bodily aspects, the corruption of the body with the sores and other things. But I think disgust isn't just a response to physical things. I think dementia patients do evoke disgust in people, and it's not because of the bodily issues, although those just add to it, or people always talk about that. Like, if I ever get that way, and they always invoke the continence issue. I don't want to live. And my point is, if the emotion of disgust is what we feel, it is extremely hard to grant them dignity and to grant them humanity. And so what that wife was telling me, and what the wife who groomed her husband's beard was telling me, is that they're mourning the loss and suffering the loss of their person, but they've gone beyond disgust. She was able to tell me that her husband took his clothes off at the barber and move beyond that and laugh and not go, that's just so awful, I wish he died. I wish we could give him Seconal or something. And I don't want to make this about that issue, but just that if we don't feel that, we could debate personhood and all this other nonsense, but I don't think we'll find humanity in these people. Yes? Or, actually, you were in the front. Several times you had your hand up.
I've heard said that, the spouse, even though they're mourning the loss of their husband or whatever, after he finally dies, that they mourn that even more because at least the body was there and he was there in their presence. So again, I'm a poet and a scientist, so I'll be the scientist. Actually not a poet, but the one study of grief in dementia was a very interesting result. Grief in survivors of terminal illness, the relatives of people who died of terminal illness. If you take a patient with cancer and their family member, and you measure, bear with me, every few weeks you measure the family member's mood prior to the date of death, and then a few weeks after the date of death, what you see with a cancer patient's family member is there's mood disorder, depressive symptoms, just bear with me, and we've got to measure it somehow, and then they die and they take off, and they're very depressed. If you do that same measurement, the study shows, in someone with dementia of the family member, there's depressive symptoms, the patient dies and they go down. Indeed, their depressive symptoms are high during the life of the patient, and after the patient dies in body, they go down. The exact opposite of the experience of cancer. And that's why I think this disease is so different in some sense, whether that's, by the way, in a spouse or adult child. There was another hand. Yeah?
It seems to me that dementia is in the eye of the beholder. Maybe the client would like just a little bit of choice. They'd like comfort. They'd like some input into what's going on. They'd like to see their loved ones. I'm not sure dignity even enters the picture for them after a certain stage. But it seems to become a big deal for the family, for a lot of people around, and people are just asking, well, who cares? I don't know. I don't feel disgusted about dementia. I've lived through both my parents' disabled old age, and
I hear you.
I consider them heroes. They're these, the greatest generation, the World War II people, they're heroes.
I hear you. I wish you could talk to the house staff who baby talked their way out of the room. Hi, Mr. Karlawish. How are you today? The patients they're seeing. Baby talk is you're this far away from getting the hell out of the room when they baby talk the patients. But you've gone.
Well,
that's not an issue for you.
How do they get out of the room then if they're baby talking?
What I was saying is, I was just, they're seeing patients on the wards, and I noticed the baby talking a lot. So, I applaud that you've reached that point. There was another hand. Did you? Yeah, Richard.
I wanted to address what you said about constructive lying. I think that was
Loving deceptions.
Loving deception or something like that. Yes, sometimes you have to not utter the exact truth, but I think what we picked up in Dr. Swabo's talk, and if you look, actually, notice you mentioned Naomi Feil, who talks about this as well. The important thing is if someone says something that's absurd, it's not to necessarily go along with it all the way, but to find the emotional center. And I think that's what
right.
Dr. Swabo was getting at. define the emotional center. So if your grandfather were to confuse you for a little girl, or another example is if the grandfather thinks that you're his sister, as a child, and starts talking to you, you don't either deny it or pretend to be the sister. You just ask about the sister. What was she like? She was important to you.
Yeah.
And to get past the immediate factual situation and find out what the person is really.
Yeah, don't let the facts get in the way of the truth. That's what I always say. I was reading we're doing a study one time that involved qualitative data, which is essentially talking to people and recording their answers verbatim and then analyzing those answers to figure out whatever it is you're trying to measure. It's a tough research methodology. And I remember I was working with this anthropologist who does that kind of methodology, and we're reading this transcript of cognitively normal people talking. And what the hell are they saying? And she laughs and says, isn't it amazing if you totally correctly transcribe spoken speech by cognitively normal people and read it, how difficult it is to understand what they're saying? And you realize, of course, that a good deal of communication, even among cognitively normal people, relies on something other than the precise words we say, but the emotions we attach to them, the gestures we use, the facial expressions we have, which are hard to capture in a transcription, the tonality of our speech and whatnot. And I think, so what am I saying? I think conversations with advanced dementia patients just bring that challenge out even more. And I picked that up very much from what you were saying with the communication with your wife, for example. Yeah.
Yeah. One thing about disgust is it often seems automatic. It's not the kind of thing that you think yourself into feeling, but you just feel disgusted by something.
Yeah, it's a feeling within kind of thing.
And my question is, I guess, as a clinician dealing with people who have these kinds of issues, when you find that family members are having the disgust reaction, what does a clinician do in that case? And is it the clinician's responsibility to deal with the family problem, or is the clinician only there to deal with the person who has the dementia?
Yeah, who are you taking care of?
And is there a way to overcome this disgust reaction when the brother won't go to the nursing home because the brother is disgusted, and you have the sense that to heal the family, it would be best if that person showed up? Is there anything that the clinicians are trained to do, think about doing in those circumstances, or is that just not even a way that we think?
Well, the simple answer that I try to use, and I'm not sure how successful, is, frankly, statements that try to evoke empathy. It must be very difficult to see your mother like this. And what you hope is that opens someone up to say, yeah, this is actually awful, I can't stand it, and I hate being around her. And okay, well, let's go there and why. So, empathy is a powerful tool if you can exploit it strategically. So that's one of my sort of strategies that I use. Yeah.
When my husband had dementia, he died of Alzheimer's about 4 years ago. I found that disgust wasn't the main problem with family and friends, but he lost his ability to speak first. And they were very frightened about being with him and being unable to speak. Some would start speaking and then he would get upset.
Yeah.
And others just would not go at all. Because what do you do?
Yeah. Yeah, I hear you. Right behind you. Yeah.
I want to answer that question.
Do, please. I think there's more wisdom in front of me than me at this podium, so I had the feeling that...
I'm a speech language pathologist over 30 years, and this is a hot topic in this society at this point. And it's good. It's bringing a lot of conversation about what do we do about your parents and your family members. And at this point, when they get to that point where they cannot talk, it does not mean that they cannot understand your physical.
Yeah, they can read emotions, certainly.
Absolutely.
Absolutely.
Your hugs, if they allow that. Your smile, if they accept that. And it's very seldom that they don't accept your smile, even if you're not saying anything. in that presence, you often know what they like, what is their pleasure, just because you've been around them. Now, it may change from moment to moment, because my mother-in-law, she has Alzheimer's, and she's had it for 8 years. And there are different levels, as you all know. So she's at that level where she's happy most of the time, but as soon as she has something sweet, this is my assessment, chocolate, her favorite candy, the mood changes, and she's more verbally aggressive. You can't tell me what to do. Why can't I have this pen? Why can't I put this cup here? But until she has that excessive amount of cookies or sweets or whatever, she is able to communicate to a point where it's not specific, but it's not quite off the mark. You have to push her in order to know. So for a nonverbal person, they read the other components, and I think helping those in the environment understand that it's okay if you sit with this person and you just pleasant or smile or you take out a book or something.
Yeah.
That's all I say.
No?
And
Time for one more question.
that's all.
If there, yes.
I think at times that people, the residents within a facility or in a home, they reflect the values of society. And for example,
Yes.
if you have one person that just has problems, eating problems, they want that person removed because it upsets them. And so I guess the point we're trying to make is that the dignity can be denied by the people that basically you're working with.
I'll leave you with this. I took care of this one guy when I was a fellow. He lived in the long stay unit, not the special care unit. His name was, I can't remember it. And he hated the food in the nursing home. And he discovered that on the first floor there was a dining room with a salad bar and other food. And he, for all his heart failure, got his way down there and would take his meals because he was paying for it. And so this was the dining room where the people who lived in the independent living floors dined. They were pissed. And they wanted him out of there. And finally someone said, we saw him pick food from the salad bar with his fingers, as if no one's ever done that. And that became a health issue. And now it's a medical issue that he couldn't be there because he was not hygienic. So he was not allowed to go down there to eat. And he mourned that. And I went to the kitchen, can't we get him some better food? He said, well, whatever. But I always remember that story, that you would think naively like they should welcome in their fellow disabled person, their fellow generation of the greatest generation to come in and join and whatnot. But no, we don't want them around. Because I don't want to be around those people. I don't want to be like that. I'm disgusted. So, I can see both sides and hear it, but I think until we sort of confront these very basic emotions, that's how we're going to find humanity in dementia, or not, as it were. And certainly history shows us that we have had times where we've decided that certain kinds of people are not human. And look what we did. So, all right.
Join me in thanking